is arranged with the support of our dear Professor Dr. Asu Faeq Salih, and the second day of the Congress will be held as co-hosted by Sulaimani University of Iraq. Welcome again. We are so excited. We are going live on YouTube. Our YouTube channel is Pediatric Webinars, TUMS. And dear attendants, please make sure your microphone is muted, your videos off, and please log in with your full name in English. And also, please do not forget to register on our web application. You will receive your certificate of attendance within 7 days. Again, please log in with your full name in English. The list of Zoom audiences will be matched with the list of registered applications for certificate of attendance on our web application. Today, we are going to have two particular sessions. First of all, we are going to start with arrhythmia in pediatrics, and then we will go on failure to thrive updates. If you are ready, we are so excited and ready to start our first session. Dear Dr. Maria. So sorry for what's happening. We are fixing the problem right now. Again, hello and welcome to our first session, Arrhythmia in Pediatrics. I'm so proud and such great honor for me to be here. As you saw in our video clip, the manager of our session will be Dr. Ilya Caruso, but he had an emergency room, so he will join us later. Please let me to introduce you him. Dr. Ilya Caruso, he received Master of Pediatric Cardiology from La Sapienza University, Rome, Italy. And also, he received his postdoctoral research fellow in Pediatrics, Division of Cardiology from Stanford University of California. He finished his cardiology specialization at Cardiology School, University of Catania, Italy. Dr. Caruso received his medical and surgical degree with vote 110/110 and praise award nominee Barbagallos and Georgi, I think so, from Cardiology School, University of Catania, Italy. Since 2018 to on, he is consultant pediatric cardiologist at Pediatric Cardiology Department, Mediterranean Pediatric Cardiology Center of Taormina Hospital, Messina, Italy. So many thanks for his invitation acceptance. I'm so sorry that we don't have him right now, but he will join us as soon as possible. Today, we are going to have 4 particular lectures on pediatric arrhythmia. First of all, again, so many thanks, dear Professor Salih, for your support, and so happy to have you here. Dear Professor Faeq Salih, sorry. He was graduated from College of Medicine since 1996, board certified general practice, higher diploma general practice, higher diploma pediatric cardiology, and fellowship of pediatric cardiology at San Donato do Italy. He was performing more than 1,000 diagnostic and interventional pediatric cardiac procedures, more than 80,000 pediatric echocardiography, and more than 1,000 fetal echocardiography. Dr. Salih is assistant professor and pediatric cardiologist. He is head of pediatric department and head of pediatric cardiology department at Pediatric Heart Hospital, Sulaimani, Iraq. It should be noted that he is one of the leaders of pediatric cardiac program in Kurdistan since 2004, performing approximately 60 missions to help people. Thank you, Dr. Asu, for joining us. Now you are co-host and you can start your lecture.
Can I share?
Yeah, of course.
Yeah. Okay. You can see my screen, right?
Yeah, your screen is awesome, full screen, and everything is good.
Okay, thank you. Really, I'm appreciating this kind of cooperation between Pediatric Department, College of Medicine, Sulaimani University, and the friends from all over Iraq to participate in such a great event, which is held by the Tehran University Medical Science Pediatric Department. So really, we are appreciating this kind of cooperation. My talk today, really our talk session is about the arrhythmias in children, and my talk specifically is about the arrhythmia-induced cardiomyopathy. Sorry. I have no disclosures. Really, I want to start with this picture in which still we were there. There was some. I mean, there is a lot controversies about how chicken and eggs comes from. So that's the issue with dilated cardiomyopathy and arrhythmia also. So one of them say, no, you back off. I was here before you. So arrhythmia is in arrhythmia-induced cardiomyopathy is a potential reversible condition in which the left ventricular dysfunction is induced or mediated by arterial or ventricular arrhythmias. Early recognition of arrhythmia-induced cardiomyopathy and prompt treatment result in symptom resolution and recovery of ventricular function. You know, there are a lot of definition for such a kind of arrhythmia, due to a lot presentation in different age groups. So the definition that's agreed upon that is it's a sufficient supraventricular and ventricular arrhythmias to result in left ventricular systolic dysfunction. The arrhythmia may be sustained or paroxysmal or highly frequent ectopic activity. The duration of arrhythmia is induced by LV. Systolic dysfunction is somewhat difficult to determine. It depends on the duration and symptoms and other factors that I will go through later. In animal models, they do pacing the heart and they get such a result with 1 to 2 month follow. When the inducing arrhythmia is corrected, resolution or restoration of the normal LV function usually occur by 6 weeks. The arrhythmia-induced cardiomyopathy first was described in 1913 and discovered to be reversible in 1962. We have 2 main types. The first one is arrhythmia-induced, in which the arrhythmia is solely responsible for the arrhythmia-induced cardiomyopathy and LV dysfunction. And in those patients, the LV function normalized upon successful treatment of arrhythmia. But in arrhythmia-mediated one, because there is some pathology behind in the myocardium. So in that case, the treatment of arrhythmia result in partial resolution of the cardiomyopathy. How about epidemiology of this disease? In the largest pediatric series in one of the study, the arterial ectopic beat what account for nearly 60% of patients. And then the permanent junctional reciprocating tachycardia also was one of the causes which account of 23%, where the most common arrhythmias was responsible for this was these 2, but ventricular arrhythmias, induced arrhythmias were uncommon. Children often present late because they fail to recognize palpitation and are unable to verbalize symptoms and comes to medical attention only after the development of heart failure. So compared with adults, different arrhythmia mechanism also responsible. So it's not just one kind of arrhythmia, it's different kind of arrhythmias responsible. Supraventricular arrhythmia account for more common types than ventricular arrhythmias in children, in contrary to adult patients. In newborn, a single sustained episode of typical supraventricular tachycardia may be unrecognized until heart failure symptoms emerge. Thus, the neonate may present with decreased LV function or even shock. In this group of prognosis and recovery cardiac function are excellent after controlling of supraventricular tachycardia. What about pathophysiology of this disease? If you look to this diagram, it looks very sophisticated, but it's not. If I subdivide the period of presentation of such a disease, so let's show you in this. This is the first 7 days. So in the first 7 days, that's the initiation of tachyarrhythmia. So in this phase, only the pump function should be normal. In this case, only there will be symptomatic activation of the cardiac cycling. But in the next 3 weeks later, after the first 7 days, there will be a phase of LV dysfunction phase in which there will be some modulation in extracellular matrix as well as cellular remodulation in the contractile dysfunction visibility in the myocardium itself, myocardium fibers, I mean. So the pump dysfunction and dilatation of LV will happen, and there will be some activation of neurohormonal activation and initiation of activation of renin-angiotensin system. So after in a month time, after 3 weeks of presentation, so there will be a defect in calcium handling and severe contractile dysfunction. In that case, your patient will present with LV failure phase, in which the pump failure happen in the LV, and there will be severe dilatation with hemodynamic compromisation, and there will be significant neurohormonal activation, and as well as there will be systemic and pulmonary edema. So in that case, that's the case of the presentation. If I am going through the mechanism, how these patients, what happens with them, what happened with their myocardium, there will be an ATP depletion, ischemia, and oxidative stress. Eventually, on the molecular level, there will be myocyte decreased contractility and increased base membrane anomalies. And as well as there will be neurohormonal activation in the form of renin-angiotensin system. On the molecular base, there will be decreased beta cell numbers and sensitivity, and there will be abnormal in calcium handling. So eventually what happens macroscopically in the heart, there will be structural changes in the form of dilatation, especially when the end systole is affected more than the end diastole. And then the LV geometry will become spherical. So that's there will be change in the sphericity, and as well as there will be decrease in the wall thickness. And eventually it will affect function of the heart with decreasing cardiac output, and as well as there will be increased systemic vascular resistance. So basis on that mechanism, the etiology behind it is very difficult to determine. Why? Because we saw patients, even though with irregularity, but you cannot predict which patients will be affected. In children with tachyarrhythmia, most often associated with arrhythmia-induced cardiomyopathy, have a narrow QRS complex with 1-to-1 AV conduction. And heart irregularity occur in pediatrics as a consequence of the tachyarrhythmia that interposed with the sinus rhythm. It's not like an adult patient when you should have a continuous tachyarrhythmia. In kids may got tachyarrhythmia intervening with sinus rhythm. And there are some genetic factors maybe related to like an SGK1 component of the myocardial, as well as because this part of the myocardium that are pro-arrhythmic factor of that, and it will link to the biochemical and functional change that happen with the NAP canals or channels. And mutation also in cardiac channels also, they are also arrhythmogenic, and as well as they will affect the contractile function of the hearts. So I am going now on the types that usually affect the myocardium in kids. The most common one is in the arterial ectopic tachycardia, which is the most common arrhythmia associated with arrhythmia-induced cardiomyopathy. And really, it's very hard to differentiate from sinus tachycardia. Why? Because the P wave morphology, it's nearby the sinus area. So eventually, you cannot differentiate from the sinus itself. Especially when you are facing those patients, they will present with heart failure. And you know, heart failure, they got tachyarrhythmia. So the mechanism behind this kind of arrhythmia is an increased automaticity. I mean, it will generate by itself. So this mechanism is most common mechanism in those patients, but also triggered by the activity and also micro reentry. The arterial tachyarrhythmias also usually occur without structural heart disease and may happen also after the surgery because may be induced by surgery and in some setting also in channelopathies. But spontaneous resolution in those patients are very common, especially in the first year of life. So that's promising for atrial ectopic tachycardia. I'll show you this ECG, which shows that warming up of the heart. So you see that there is the sinus beat, then it is warming up in some phases. So that's the atrial ectopic tachycardia as an example, because you can see warming up, slowing down, and going up again. The second most common is the permanent junctional reciprocal tachycardia, in which we have an accessory pathway mediated tachyarrhythmia, and characteristically they got long RP, not PR, take care of this point, RP interval that occur predominantly in infant and children, and the pathway usually is posteroseptal. The pathway is tortuous and slow conducting. That's why it's very tachyarrhythmic. In the recent review in one of the papers, found that 27 more patients with the permanent reciprocal tachyarrhythmias are during fetal life, and 7% of them presented with hydropis. And the initial clinical courses of this kind of arrhythmia is not benign, and spontaneous resolution is unlikely. So usually you need medical therapy for those patients, usually for neonate and infant, and beta blocker as well as combination with amiodarone and other drugs may be used to control. Eventually you'll end up with ablation. If I am showing this ECG, which shows the tachyarrhythmic phase when there is SVT, but in the slowing phase, we have inverted P wave in inferior leads, as well as we have RP interval more prolonged than the PR interval. That's very characteristic point here. The third type, which is junctional ectopic tachycardia, is most commonly seen in the small children following congenital heart surgery. And it's due to automaticity in the region of AV junction. We have congenital jet and presenting with infancy associated with high morbidity and mortality. And medical management usually not just by but one drug, which is beta blocker. So in majority, we may use 2 drugs and more and combination, as well as they will end up with catheter ablation if not resolved later on. The fourth cause of the arrhythmia-induced cardiomyopathy is the ventricular tachycardia, even the premature ventricular contractions. So it's rare, usually rare in children, more common with adult patients, but it's a problem with the Purkinje fibers, and it will affect both ventricles. And sometimes premature ventricular ectopy is causing arrhythmia-induced cardiomyopathy in children. I'll show you this ECG with junctional ectopic, in which we have the QRS compared usually narrow and but maybe broad in bundle branch block cases, and the relation between ventricle and atrial will be 1-to-1, and as well as the RP interval is shorter. It's not like the previous one. So here there will be an atrioventricular dissociation and slow atrial pacing more than the ventricular pacing. And in these cases, we may differentiate AVNRT versus jet by adenosine injection. So why it happens with kids, this kind of arrhythmia? It's not established that why it happens with some people and it's not with other people. So maybe this is a risk factor for that. Maybe the type of arrhythmia, rate, duration, and also the age of the patient. And also it's a determinant that underlying cardiac disease, medication, as well as medical problems. In children, the patient present with the sign of heart failure, the shortness of breath, fatigue, and exercise. So many of you knows that also on physical examination, we may not take arrhythmia at first, then eventually edema, poor perfusion, and signs of heart failure, as well as increased jugular venous pressure and hepatomegaly. Prognosis of those patients are mainly depend on the rate and duration as well as age. And usually younger children, particularly newborn infants, have more complete recovery courses. And recovery period, most of the studies show that demonstration of great LV function recovery defined by LV ejection fraction more than 50% will happen in 1 month after the termination, and controlling the tachyarrhythmia, followed by slower improvement in 1 year time. I just want to share this case at the end of my slides. This is a case, EM, she's a 6-year-old female, presents with pediatric cardiology with tachyarrhythmia, tachypnea, sweating, organomegaly. 1 week earlier, she was presented again with tachyarrhythmia to other hospital outside the main city and treated as a case of fever-related tachyarrhythmia without documentation of tachyarrhythmia type by ECG. After admission to the hospital, who was presented with shock, mottling, and as well as all signs, symptoms of heart failure, ECG monitoring shows tachyarrhythmia more than 250 with P waves, and it was diagnosed as a case of atrial ectopic tachycardia, which necessitated immediate support with the antiarrhythmic, inotrope, and diuretics. And the patient on examination was shocked. So on echo, the patient was dysfunctional with dilated thin wall, LV, no coronary disease, severe MR, and severe TR. COVID tests were positive, antibody, antibody were negative. All cardiac enzymes were high. Throughout 1 month follow-up later, cardiac enzymes still the same. The patient responded in 2 days dramatically with amiodarone and inotropes. Second echo shows better function. I'll just show you the echo and how the hearts present during the attack. And now, at the end of my presentation, are you satisfied with which of them causing the other one? We are still, maybe we are in the mess. So taking home message that tachyarrhythmia result in arrhythmia-induced cardiomyopathy different from those in adult. There is a predictable pattern of resolution with treatment. Recovery seems independent of treatment strategy. Recovery is predictable following arrhythmia control, and failure recovery should be investigated and searched for the cause, why it happens. Although index presentation may take months to clinically present, recurrent arrhythmia can result in rapid decline in ventricular function and development of heart failure. And thank you for your attention and for your time.
Also, that was great. As a cardiologist, I do really enjoyed your presentation. It was fluent, it was educational, and I myself learned from you. There are some points that I want to discuss with you also. Yes. You just emphasized that there are types of arrhythmia that are more susceptible to cardiomyopathy. For example, the arrhythmia that we call them incessant, yes, such as ectopic atrial tachycardia or PJRT, or some of those that cannot be solely resolved with administration of adenosine. Right. But I want to emphasize something else, and if you agree with me, with the acute onset arrhythmia, there should not be a panic with the physicians. They should give some time for the drugs, for the medications to start their action. Many of the drugs need some time to get to the level that you can see the result of their administrations. Right. For example, when you use something like amiodarone for a patient, there may be a time left between the initiation of the action and the administration. So increasing the dosage, or maybe adding another drug, another medication to that will be the beginning of the side effects. Do you agree with me?
Yeah, I agree totally with you, Dr. Isai. We are facing patients like, for example, they present with arrhythmia, and the resident here told me that we need to just add another drug. I say just wait for an effect because you need time. Sometimes you are giving loading dose for a drug and it will not work. So you can use, for example, the second dose, but don't exceed that again, because you can later put on a maintenance and look for your patient, just taking care about other things like pulmonary edema and other things. So you may add other drugs in the form of non-arrhythmic drugs, let's say that. And so in that case, you should wait for a while, at least 24, 48 hours to look for the results.
Also, there are so many topics that we can talk about. So let's go to the next topic, and at the end of the session, we will be together, and hopefully we can have the moderator of the session with us, so we can talk about the main topics that I'm sure that will be very useful for our pediatrician colleagues here, and also for the pediatric cardiology residents that I see they are in the audiences. So Mahia, back to you.
Thank you, dear Dr. Asu, for sharing us your knowledge. I can't find Dr. Hamdi in our audiences, so if you agree, we will continue with neonatal arrhythmia with Dr. Khalid Ahmad. Okay?
Yeah.
Thank you.
Okay, good afternoon, everyone.
Sorry, Doctor, if you allow me, I would like to introduce you.
Okay.
Okay, do you have my screen? Dr. Khalid Ahmad Khalid is congenital and structural interventional cardiologist at Basra Cardiac Center, Basra Medical College, Iraq. So many thanks for accepting our invitation, dear Dr. Khalid. Of course, your knowledge will be really exciting for our audiences and attendees. Your co-host, and you can share your screen. Thank you so much.
Thank you. You see my slides, please?
Yeah, I can see your slides, but not in full screen.
Now in full screen?
Yeah, thank you.
Okay.
Awesome.
Ladies and gentlemen, good afternoon. Thank you for letting me to present with you online. Let me now start with my topic, neonatal arrhythmias and recognition and management. Start with the introduction. The prevalence of a clinically significant neonatal arrhythmias is not well described, but approximately 1 to 5% in all neonates. The abnormalities of heart rate and rhythms, both benign and malignant type, are frequently detected in neonates who are being monitored continuously on cardiac telemetry in intensive care setting. The most important step in the analysis of neonatal arrhythmia is primarily based on the heart rate and rhythm. The normal heart rate in newborn starts from 90 to 180 beats per minute. Certain forms of tachycardia can present with a fixed heart rate at higher limits of the normal range, and occasionally even with a normal heart rate of 4/8. The two aspects for assessment of such patient are to evaluate the heart rate trend and identify any extra cardiac influences that may affecting the heart rate. Start with the heart rate trends. Heart rate trends aid in understanding the underlying cardiac mechanism for the tachycardia. First, a slow rise in the heart rate usually points to the tachycardia caused by an automatic focus in which there is a repetitive firing from a single focus within the heart, such as seen in sinus tachycardia or automatic focal arterial tachycardia. So there is slow firing in the train. The other example is abrupt onset of tachycardia with a sustained and fixed rate followed by abrupt termination. So sudden rise and sudden termination of the rhythm. This suggests a reentrant mechanism of tachycardia like AVRT or atrial flutter. The second point is the rhythm. A normal or sinus rhythm refers to atrial activation starting from the sinus node, characterized by the presence of a normal P wave excess and by the synchronous occurrence of a P wave before every QRS complex with a normal PR enter. As all of us know, the arrhythmia is a disturbance in the heart rate and or rhythm. So arrhythmia can be classified as a premature complexes, bradycardias, tachycardias. Start with the premature complexes, which can arise from the atrium, as in premature atrial complexes, or ventricle, or atrioventricular junction. The frequent ectopy can be related to electrolyte imbalance, irritation from intracardiac central venous catheter, or structurally abnormal heart. The premature atrial can be contractions or complexes can be normally conducted as in the first strip. The P wave inverted differ from the other P wave, and the QRS is normal similar to that of others. That means the P wave is conducted into the ventricle through the AV, or could be conducted apparently through accessory pathway, as in the second strip, result in wide a QRS complex, or could be non-conducted. So there's a missed beat, or there is atrial activity without QRS ventricular activity. The typical approach to frequent PACs or PVCs to ensure that the infant has normal electrolytes and there is no tip in the central venous catheter, not irritate the heart, and to check the heart by the echocardiography to exclude cardiac anomalies. Treatment of PACs is based on the underlying cause. Typically, a specific cause is not found, and monitoring and re-evaluation might be all that is required. The second category of arrhythmias, bradycardia. Bradycardia in neonate can be broadly classified into sinus bradycardia and heart block. It is common to see combination of ectopic atrial junctional ventricular escape rhythm with sinus bradycardia. Sinus bradycardia has myriad causes, including multisystemic abnormality like cardiorespiratory failure, raised intracranial pressure. The second category of bradycardia is heart block. Heart block denote AV conduction disturbances and can occur in congenital abnormal as congenital heart block, or acquired in infection, surgery, or even metabolic abnormality. The first degree heart block when there is only prolongation of the PR interval with normally conducted. The second heart rate refer an intermittent AV conduction, often in a regular pattern, divided into MOPITS 1 and 2. MOPITS 1 when there is a progressive prolongation of the PR interval followed by loss of conduction of atrial activity. Typically implies disease within the AV node itself. It usually carry a benign prognosis and is usually secondary to medication conditions associated with increased vagal tone. MOPS 2, stable PR interval with intermittent loss. You see here the PR is fixed, then there is a loss of the QRS. MOPS 2 carries more a worrisome prognosis because it signifies conduction disease distal to the AV node within the Hesperker system and can precede complete heart block without an adequate escape rhythm. So patient with MOPS 2 may require early pacemaker implantation. The third degree AV block or complete heart block refers to the absence of any atrial electrical conduction to the ventricles. In neonates, complete heart block is usually congenital and can be autoimmune, idiopathic, or associated with congenital heart disease as NCC-TGA, congenitally corrected TGA. Complete heart block can also be secondary following cardiac surgery, or catheter-based intervention, medication, or profound metabolic imbalance. The indications for permanent pacemaker in patients with congenital complete heart block, including symptomatic patient, ventricular dysfunction, resting heart rate less than 55 per minute, and in structurally abnormal heart less than 70, and ventricular escape rhythm or complex ventricular ectopy. The third category of arrhythmias is the tachycardia. The common classification of tachycardia, either supraventricular tachycardia above the bundle office or ventricular tachycardia. Other classification is narrow and wide QRS complex tachycardia. The narrow QRS complex tachycardia, either automatic or reentrant tachycardia, including AVRT, atrioventricular reentrant tachycardia, atrioventricular nodal reentrant tachycardia, focal atrial tachycardia, atrial flutter, atrial fibrillation, and junctional tachycardia. So start with the first category, which is automatic narrow QRS complex tachycardia, including FAT, focal atrial, and junctional tachycardia. Automatic tachycardia typically have gradual warm up and a gradual termination, as in the trend say here, the gradual warm up and the gradual termination. Start with the focal atrial tachycardia, refer to an abnormal firing from a focus other than the sinus node. FAT is commonly encountered in the post-operative state or in congenital heart disease or in structural heart disease, and can occur in even structurally normal heart. Patients with FAT can present with either frequent bursts of atrial ectopy or can have sustained tachycardia with a gradual warm up and cool down. ECG show an abnormal P wave morphology and excess inverted in inferior leads due to its ectopic origin, which can be useful to distinguish it from the sinus tachycardia. Because automatic tachycardias are the result of an abnormal focal firing, so cardioversion would be ineffective or maybe transiently suppress the focus, but recurrence is the usual. Adenosine administration typically does not effective other than possibly transient suppression. Adenosine causes AV block without affecting the arterial rate, and hence can be used to distinguish FAT from reentrant tachycardia from sinus tachycardia. So not only therapeutic, can be used adenosine as a diagnostic. But if left, can cause tachycardia-induced cardiomyopathy. Typically treatment including beta blocker, or could be used flecainide, sotalol, amiodarone in unresponsive patient. The outcome in infant without congenital heart disease or cardiac surgery are excellent, and the condition usually resolves spontaneously in a few months. The second one is the junctional ectopic tachycardia, JET, which is abnormal firing distal to the AV node in the bundle of his. JET could be following surgery or congenital or idiopathic in nature. ECG characterized by absence of P wave because of the atrial activity occur at the same time of QRS, ventricular activity, or could be there is a retrograde atrial activity or complete dissociation, AV electrical discordance. These tachycardias can be refractory to medication and might require early catheter-based ablation. The other type of neurocomplex is reentrant neurocomplex type. Reentrant tachycardia refers to a tachycardia using an abnormal electrical circuit within the heart. An abnormal circuit usually involves at least two separated electrical pathways with different electrophysiologic properties that circle around a fixed obstacle. Common narrow QRS complex reentrant tachycardia, including atrioventricular reentrant tachycardia when there is an accessory pathway, atrioventricular nodal reentrant tachycardia within the AV node itself, or atrial flutter and atrial fibrillation. Start with AVRT, which refer to reentrant tachycardias caused by an accessory pathway. Accessory pathway act as a second site for electrical communication between atria and ventricle. AB can have both antegrade atrium to ventricle, or retrograde ventricle to atrium, or have only one. APS with integrate conduction are termed manifest APS. Why? Because it results in a visible delta wave, or what is called WBW pattern. While the APS without integrate conduction, it's called concealed, because there is no delta wave on the resting ECG. The common form of AVRT is called an orthodromic AVRT. That means integrate conduction via the AV node and the retrograde conduction via the accessory pathway. Because integrate conduction is through the AV node, so the QRS is narrow QRS. Neonates who are not recognized to have SVT may develop ventricular dysfunction after 6 to 12 hours and potential hemodynamic instabilities. Acute management in hemodynamically stable patients involving attempting vagal maneuvers such as ice on the face or rectal stimulation using a rectal thermometer. If vagal maneuvers fail, then adenosine can be used. So failure of response or refractory to response, you think about 3 points. First, to make certain that the rhythm strip is consistent with AVRT rather than autonomic fat or arterial flutter, in which case the adenosine might not affect the arterial rate and only causing transient AV block. So here adenosine can be helpful in the diagnosis. To ensure there is absence of a deep-seated central line that is cause reinitiation of frequent PACs and causing SVT. To consider the use of other medication like IV procainamide or IV ismolol. In patients with hemodynamically unstable SVT, prompt cardioversion per the PALS guidelines is recommended. Adenosine testing is not only therapeutic as mentioned before, but can be distinguished the type of the rhythm and differentiate SVT from fat or from arterial flutter, as in this, after administration of adenosine, the flutter wave become more clear. There is no change in the rate of the atrium, but there is a change in the rate of the ventricle. So it is diagnostic rather than therapeutic. The second type of reentrant is AVNRT. AVNRT reentrant within the AV node, where there is a fast and a slow conducting arterial input to the AV node. In typical type, the antegrade limb of the circuit is the slow pathway, and the retrograde one is the fast pathway. On ECG, the arterial activity in infants is typically not seen because it's occurs simultaneous with the ventricular activation. While in atypical AVNRT, the antegrade limb is the circuit of the fast pathway, while present with the relatively normal appearing PR interval on the ECG because of the long RB interval. The P wave axis in lead AVF is helpful and always negative because it signifies retrograde conduction. So P wave is very important in AVF and its direction is downward. Arterial flutter is usually caused by functional reentrant circuit within the atrium, right atrium, the arterial rate ranging from 300 to 600 with ventricular response 180 to 220. Adenosine not cause recovery to sinus, but it will help to diagnose. Management usually need cardioversion, and prognosis is excellent, and recurrence is rare after cardioversion. Atrial fibrillation is rare in infant, on neonate, infant, and even in children. Treatment is by cardioversion. The last category is wide complex arrhythmias, including SVT with aberration or apparent conduction, antidromic AVRT, and VTs. Start with SVT with aberration in the presence of bundle branch block. So this can produce a wide complex tachycardia and can mislead one to consider it as a VT. So response to adenosine can be both diagnostic and therapeutic in such patients. Antidromic AVRT in rare instance in infants or in patients with manifest pre-excitation. This results in ventricular activation exclusively via the AB accessory pathway, resulting in a wide complex rhythm. Management is similar to orthodromic AVRT. Ventricular tachycardia refers to an normal rhythm originating in the ventricle myocardium or from the distal His Purkinje system below the bundle of His. The most common type is accelerated idioventricular rhythm. The term that's mean used when the rhythm originates from a single focus in the ventricle and is within 10% of underlying sinus rhythm. Neonates are usually asymptomatic unless they have ventricular dysfunction because of typically entry cardiac pathology and related cardiac pathology. AIVR carry a benign prognosis once structural heart disease and metabolic disarray are ruled out. Outflow tract VT is another benign form of tachycardia that can present with frequent PACs or VT in patients with a structurally normal heart. These tachycardias or PVCs typically arise from the RVOT and have a left bundle branch block morphology with an inferior QRS. That means the origin is RVOT. This is the example for the PVCs with
Dear Professor, we lost your voice.
Khalid, you are still muted. Okay, that's okay.
Okay, thank you. That's all. Thank you. Sorry.
Thank you very much, Dr. Khalid. First of all, nice to meet you, and we all enjoyed your educational presentation. It was very good to review all the neonatal arrhythmia in one presentation, so fluent and so educational. If I may, I would like to add some points that, in my opinion, will be important for our colleagues, pediatricians, to remember about the neonatal arrhythmias. First of all, if they encounter a patient of neonatal arrhythmia, it is better to remember that some of these arrhythmia are accompanied with metabolic and also genetic syndromes. For example, some of them are the first appearance of some kinds of cardiomyopathies, for example, hypertrophic cardiomyopathies. So they should keep in mind that they should think the patient as a whole set, not just go for the arrhythmia and forgot what is happening in other parts of the body. That's one point, and another point is some channelopathies that can be happened as arrhythmias, and they should remember that short QT syndrome mostly it is not so usual for a neonate to present as short QT syndrome, but if they present, they will present as supraventricular arrhythmias, and also long QT syndrome for the neonate is still happening, and they should keep in mind that it is very important to go for the channelopathies, especially the abnormalities of QT. So these were some points that I think it was important for them to remember. And just one question, Khalid, have you ever encountered a neonate with congenital jet?
Actually, not. In my practice, I not face congenital jet.
Yes. Because we have your referral center in Tehran, we have some cases with neonatal arrhythmia that are rare, you know. About the post-surgical jet, we have so many cases of that because we are the referring center here and we can see it every day. I can say every day we can say cases of that. But neonatal or congenital jet, I have 2 cases of that, and the prognosis of those patients is very poor, and both of them, unfortunately, expired within first 6 months of their lives. So congenital jet has a very poor prognosis, even with treatment. With treatment, we cannot do, we cannot expect a very good prognosis for them. Thank you very much, Khalid.
Thank you.
At the end of the session, we are you staying with us till the end of the session?
Yes, I will be with you.
Okay, so we shall have you until we shall have you in the Q&A section. Thank you.
See you. Thank you for you. Thank you.
So many thanks, dear Dr. Khalid, for your educational lecture. That was really helpful to me. We have 2 questions in the chat section, so I will ask them at the end of the session in our Q&A part. Thank you again for your joining us. Now we are going, thank you. Now we are going to continue our session with the topic around arrhythmias in congenital heart disease by dear Professor Dr. Firas Alkubaisi. Dr. Firas Alkubaisi is consultant pediatric cardiologist. He is fellow of Iraqi Board of Medical Specialties in Pediatrics and Cardiology, working at Ibn al-Nafees Cardiac Center, Baghdad, Iraq. Dear Dr. Alkubaisi, hello, dear Professor.
Yeah. Hello, good evening.
Good evening. Welcome to our Congress, and thanks for accepting our invitation. It's our honor to have you here with us.
Thank you very much for this nice presentation.
Thank you.
It's my honor to be part of this conference, and I hope next time we'll meet with all of you in person, inshallah.
Yeah, of course. Inshallah, we will finish this pandemic and we will have you, we will see you soon.
So you are seeing my slides?
Yeah, that's great.
Okay, welcome again. My topic will be about the arrhythmias in congenital heart disease. In children with structurally normal heart, the mechanism of arrhythmia are usually the same as in adult patients. Some arrhythmias are particularly associated with young age, and they are very rarely seen in adult patients. Arrhythmias in congenital heart disease may be associated either with the underlying abnormality or may result from surgical intervention. Chronic hemodynamic stress of congenital heart disease might create an electrophysiological and anatomical substrate highly favorable for reentrant arrhythmias. So, as a general rule, prescription of antiarrhythmic drugs require clear diagnosis and ECG documentation of a given arrhythmia. Risk-benefit analysis of drug therapy should be considered when facing an arrhythmia in a child. Prophylactic antiarrhythmic drugs is given only to protect the child from recurrent SVTs until the disease will cease spontaneously. In the last years, radiofrequency ablations are progressively used as a curative therapy for tachyarrhythmias in children with or without congenital heart disease. We have, in the last year, 3-dimensional mapping and non-fluoroscopic navigation techniques as enhanced catheter technology have further improved safety and efficacy in congenital heart disease with complex arrhythmias. During the last years, cardiac devices, pacemakers, and ICDs have developed rapidly. The pacing generator size has diminished and the pacing leads have become progressively thinner. This makes cardiac pacing in children easier, although no dedicated pediatric pacing systems exist. So, to understand the anatomy of to understand the arrhythmia in congenital heart disease, we have to know first the anatomy of the conduction system. So what is the normal? And then we have to know what is the abnormal to understand the mechanism of arrhythmia in congenital heart disease. And this will aid the surgeons next for the radiofrequency ablations treatment. So I will go fast through the normal anatomy. We have the sinus node. All of us know that we have the sinus node. It is in the lateral margin of the junction between the SBC and RA. We have the AV node. It is in the triangle of Koch. We have the AV conduction bundle, which continues as a short non-branching portion before it becomes the branching bundle. And we have the Purkinje network. In a congenital heart block, it can occur in congenital malformed hearts or in otherwise normal hearts, mostly seen in LTGA, mirror arrangement of atrial appendages and some AV septal defects, maybe also associated with some connective tissue diseases. We have some accessory AV connections. We have a left-sided parietal pathways, and we have the right-sided parietal pathways. So the conduction system in the congenitally malformed hearts, the SA node. When we have a situs solitus, the SA node is its normal position. Abnormal position of the SA node had been found in the hearts with juxtaposition of atrial appendages and in the hearts with an atrial arrangement other than normal. Left juxtaposition have an anteriorly displaced SA node. Right juxtaposition, it is rare and does not affect the location of the SA node. In a situs inversus, the RA and SA node are on the left side of the patient. In acyclinia syndrome, they are bilateral SA nodes. In polycyclinia, SA nodes are not in their anticipated position. AV conduction system. In a concordant AV connections, a regularly posteriorly located AV conduction system is to be expected. In situs inversus, there is a mirror image distribution of the AV conduction system. Heart defects with normal aligned septal structure. Here we are talking about the VSD, the AV septal defect on TOF. When we have a perimembranous defect, then the AV node is in the membranous septum at their posterior inferior border that contains the AV conduction bundle. Here, the non-branching bundle is longer than in normal hearts, and the normal leftward shift of the bundle still brings it into the LVOT, making this part of the defect the most critical area for avoiding the injury to the conduction system during the surgery. In a muscular VSDs, they have a varying relationship to the AV conduction axis. Those defects between the ventricular outlets are remote from the axis, while the apical trabecular VSDs are in the environs of ramifications of the bundle branches. A perimembranous VSD with a muscular elliptic extension, the conduction axis traverses the muscular bridge separating the defects. In a doubly committed VSD, there's a varying relationship and it's in its posterior inferior margin. In an AV septal defects, the AV node is displaced posterior inferiorly at the atrial site of the junction between the atria and ventricular septum. In a heart defects with a malalignment of the septal structures, including this tricuspid valve straddling, the LTGA and univentricular hearts. In tricuspid valve straddling, the AV node is located posteriorly inferiorly, but it is displaced. In an LTGA, the AV node is located anterolaterally, and sometimes there is a second AV node may be present. In a univentricular heart, the AV node is at the acute marginal position of the right AV orifice. In a tricuspid atresia, the AV node is at the muscular roof on the muscular floor of the RA. So in summary, the cardiac conduction system, both in a congenital heart disease and structurally normal hearts, shows variability that accounts for some of the rhythm abnormalities. Cardiac surgeons, electrophysiologists, and interventionists should know the location of the conduction system, whether in repairing the cardiac malformation or in modifying the SA or AV nodes. Epidemiology and pathophysiology of arrhythmias in congenital heart disease. Junctional ectopic tachycardia, JET, it's a malignant tachycardia. It occurs after surgical correction of a congenital heart disease. There are a lot of variables, including the age less than 1 year, a history of heart failure, high body temperature, longer cardiopulmonary bypass time, type of cardioplegia, higher levels of postoperative troponin test or creatinine kinase, and longer ventilator support. It's most frequently seen after VSD closure, AV septal repair, and TOF repair. So what is the causes of post-surgical JET? It's a suture line that causing an edema, inflammation, or hemorrhage to the AV node, or there is a direct damage to the AV node, or stretching the AV node by the VSD exposure or RVOT resection. Postoperative atrial arrhythmias in congenital heart disease. We have an early and late postoperative arrhythmias. It's caused by electropathological alterations secondary to congenital defect, consequence of a cardiac surgery, or hemodynamic abnormalities. Most frequently, it is an SVT, jet, AV block, or AF. Approximately, it is about 10%, and the most important risk factor is the type of the surgery performed. The late postoperative arrhythmias, it's mainly atrial flutter and intra-atrial reentrant tachycardias. This happens months or years after surgery. This is mostly in Fontan, Mastard, Sinning procedures, or TOF repair. Variables include complexity of the congenital heart disease, the number of surgery performed, hemodynamic status, and the time after the surgery. So, arrhythmias in Fontan circulation. Early, we have an early tachyarrhythmias, which is mostly atrial flutter. It's arising during the first 30 days after the cardiac surgery. And we have late complications, and this includes AF, atrial flutter, and intra-atrial reentrant tachycardias. So what is the risk factors for arrhythmias in Fontan? We have the RA enlargement, high RA pressure, SA node dysfunction, older age at time of surgery, high PA pressure, low oxygen saturation, and preoperative arrhythmias. As time passed after surgery, there is an increased incidence of arrhythmia, and it is estimated to be 21% after 15 years. Arrhythmias in TGA. Before surgery, many kinds of arrhythmias might happen, including sinus bradycardia, sinoatrial block, junctional escape rhythm, and etc. The incidence of brady and tachyarrhythmias after the physiological TGA correction surgery, which is the master, was very high. It's about 30 to 100%, with a sudden cardiac death in 2 to 8%. It is due to damage to the SA node, AV node, atrial muscle, or interarterial pathways, and this is due to extensiveness of the surgical repair. Sinning is always compared or comparable to master, while the Jatini operation, there is a lower incidence of arrhythmias, only 5%, and this is due to the limited surgery involving the atria. Arrhythmias in ASD. Preoperative arrhythmias, they are uncommon, and this depends on the age of the patient, the shunt size, and the PA pressure. RV volume overload causing atrial stretching, which enhance the development of reentrant tachyarrhythmias in ASDs. Early intervention prevent the occurrence. Postoperative tachyarrhythmias are common, 8 to 70%, frequently AF and flutter. The SVC cannulation approach have a lower incidence than the RA cannulation approach. So as much as we can minimize the RA manipulation, we will have less incidence of arrhythmias. Transcatheter approach is having a lower incidence than the surgical approach. What about arrhythmias in TOF? We have a transarterial and transventricular approach in correction of TOF patients. The transarterial approach is nowadays preferred to reduce the incidence of ventricular arrhythmias. Postoperative SVTs are an important cause of morbidity. SVTs incidence increase after TOF correction because of PI, arterial volume overload, older age at repair, previous palliation with Watterson or Potts anastomosis. VTs are the cause of sudden cardiac death, 1 to 3% in operated TOF. Risk factors for VTs, including older age at repair, increased RV systolic pressure, moderate to severe PI, and ventricular dysfunction. The VSD, the RVOT patch, and ventriculotomy scar are the part of reentrant circuits for the VTs in TOF patients. Postoperative ventricular arrhythmias in congenital heart disease. We have a ventricular ectopics, and this is very frequent and mostly due to hypokalemia, while ventricular tachycardias are due to ventriculotomy scar, fibrotic tissue due to long-standing cyanosis, valvular regurgitation causing ventricular dilatation. VTs occur mainly after surgery for TOF and LVOT. What is the risk factors? Old age or repair, poor hemodynamic status, longer duration postoperatively, and QRS prolongation. VTs are assumed to be the main cause of sudden cardiac death in congenital heart disease. Few words about the genetics in pediatric arrhythmias. We have inherited arrhythmias can be caused by mutation in genes mainly encoding 4 types of proteins. We have the sarcomeric causing the HOCM, we have the cytoskeletal causing the DCM, desmosomal causing the arrhythmogenic RV, and the ion channels causing the channelopathies. HOCM, most common genetic cardiovascular disorder affecting 1 of 500 of general population. It is an asymmetric LV hypertrophy. It can range from asymptomatic to sudden cardiac death, minimal hypertrophy to severe, and septal to apical hypertrophy. It's the most common cause of sudden cardiac death in young. 90% are inherited. It's autosomal dominant. Risk stratification for sudden cardiac death in HOCM children includes the LV wall thickness, Z score more than 6, and an abnormal blood pressure response to exercise. Arrhythmogenic RV cardiomyopathy. It's an RV dysfunction. It's also inherited. Fibrofatty replacement of the RV wall, sometimes LV involvement. It's about 1 of 5,000, 80% are male, 20% of all sudden cardiac death. It's an autosomal dominant. We have a particular, the Knox's syndrome, which is an arrhythmogenic RV palmoplantar keratoderma with a curly hair. The clinical features may range from subclinical to sudden cardiac death, palpitation, syncope, or RV failure requiring heart transplantation. Channelopathies, usually structurally normal hearts. Sudden cardiac death may be the first manifestation. Sometimes ECG are normal, making the diagnosis difficult, and genetic testing contributes to the diagnosis. Few notes about the long QT syndrome. It's characterized by prolongation of the QT interval. It's responsible for VT syncope, sudden cardiac death. Could be congenital or acquired. Acquired due to the drugs, electrolyte disturbance. Could be asymptomatic to sudden cardiac death. We have particularly the autosomal dominant Romanov-Wald syndrome or the autosomal recessive Jervell and Lang-Nielsen syndrome. Short QT syndrome, and as Dr. Hassan thankfully said, that it's first described in 2000. It's highly malignant. QT interval less than 330 milliseconds. The lack of symptoms to range. The symptoms range from asymptomatic to recurrent syncope, sudden cardiac death. It's a possible cause of death in nursing infant. It's an autosomal dominant. We have 3 types, type 1, 2, and 3, and it may present with bradycardia in the neonates. Brugada syndrome, it's hereditary, responsible for VF and sudden cardiac death in young. It's mainly in structurally normal hearts, but it can happen in congenitally malformed hearts. Sudden cardiac death might happen at any age, mainly affecting the males. And first ever patient recorded was 2 years old child. There is a 20 to 50% family history of sudden cardiac death. We have the catecholamergic polymorphic VT. It's first described in 1975. It's heritable and is triggered by the adrenergic stimulus during exertion, extreme stress or emotion, mainly affecting children 7 to 9 years old, but it can affect infants to 40 years, usually male. Sudden cardiac death, ECG is normal, significant ventricular ectopics after exercise. It's an autosomal dominant. We have the lethal Anderson-Towle syndrome. Mortality actually is very high, 30 to 50% by the age of 20, and the earlier the episodes, the poorer the prognosis. Atrial fibrillation, usually it's in adults. Idiopathic VF, spontaneous VF without identified structure or electrical heart disease, may account for 10% of sudden cardiac death. We have progressive cardiac conduction disease, the Lev-Leonardi syndrome. It's rare. There is a disruption of the conduction system. Block gradually develops, resulting in ventricular arrhythmias and asystolia. That's a genetic, first described in 1999. Sixth sinus syndrome, we have the sinus node dysfunction. Syncopal attacks may need lifelong pacemaker therapy. Wolff-Parkinson-White syndrome, double excitation of the heart induced by pre-excitation, usually takes the form of SVTs, autosomal dominant, and sometimes associated with HOCM. So what is the pharmacological treatment for arrhythmias? Antiarrhythmic drug therapy in children without documented arrhythmias. As a rule, prescription of antiarrhythmic drugs require a clear diagnosis with an ECG documentation of a given arrhythmia. Thus, the sole complaint of palpitation or other symptoms evoking the suspicion of possible arrhythmia is not a sufficient reason to give an antiarrhythmic drugs. Antiarrhythmic drugs therapy in children with documented neuro-QRS tachycardia. And here we are talking mostly about the SVTs. And this is the table showing the acute treatment for hemodynamically stable patients. We know that we have to start with the vagal maneuvers, ice immersion, gastric tube insertion in infants, Valsalva, etc. And if it fails, then we have the adenosine, verapamil, flecainide, propafenone, and amiodarone. Prophylactic antiarrhythmic drug treatment of the neuro-QRS tachycardia. The highest incidence of SVTs is in infants and young children. The majority of SVTs will fade away with the growing. Invasive therapy is limited to drug refractory or life-threatening attacks. Most clinicians adopted a strategy of giving prophylactic anti-arrhythmic drugs during the first 6 to 12 months of life. Various combinations of drugs have been documented to be effective in the therapy of SVT refractory to single drug management. SVT less than 1 year age, usually it grows away with time. SVT more than 1 year age, it's less likely growing out. All patients should know how to terminate their SVT with Valsalva maneuver. And there is a pill-on-pocket approach, which is for a rare, infrequent, well-tolerated, educated children. And this is table suggested the doses and side effects of the commonly used oral prophylactic antiarrhythmic drugs. Beta blockers are main used. Combined beta blockers and class 3 antiarrhythmic drugs such as sotalol or calcium channel blockers are the most widely used drugs. Chronic treatment is to be considered in the first few years of life in case of poorly tolerated symptoms and frequent attacks until the patient reaches an age which is nowadays elective, invasive, and curative treatment with ablation can be recommended. Any patient more than 5 years with recurrent attacks and controlled by medication will start directly with ablation. Antiarrhythmic drug therapy in children with documented wide QRS tachycardia. VT affects all age groups, including newborns and small children. VT should always be considered when facing any wide QRS tachycardia, and the treatment should be directed as for VT unless proved otherwise, as the potential harm of treating an SVT as VT is very little compared with the converse. Acute treatment of wide QRS tachycardia. This needs an immediate treatment. Hemodynamically unstable patient, we have started with DC, 1 to 2 joule per kg, double for each unsuccessful attempt. While those hemodynamically stable, we start with the lidocaine bolus infusion. If it is unsuccessful, then cordaron, and then ismolol, and finally DC. Prophylactic antiarrhythmic drug treatment for the wide QRS tachycardia, this should be directed to the specific diagnosis. Special circumstances in congenital heart disease. Supraventricular and ventricular tachyarrhythmias may coexist in the same patient, as in repair TOF and Senning master corrective operations for TDA. Atrial flutter is the most frequent and typical late complication in post-operative patients due to an atriotomy scar. Once it occurs, it is not self-limiting, but a long-term management problem. Drugs were disappointing. Radiofrequency ablations will be needed. Life-threatening VT are rare among patients with congenital heart disease, either prior or after surgery. The incidence of VT will increase with increasing age of the child. VT after TOF correction, 12%, with an 8% sudden cardiac death after 21 years follow-up period. Beta blockers are used for the minimally symptomatic and ablations for those severely symptomatic. Fetal arrhythmias, 2% of pregnancies after 20 weeks of gestation, started after 20 weeks of gestation, and only 10% of them are significant. The majority are premature atrial contractions, usually benign, but if it is associated with LV dissection, high drops, or cardiomegaly, then it may suggest an SVT. Ventricular premature beats indicates myocardial disease. Assessment of fetal rhythm can be challenging, but the most feasible technique is echo, using the Ahmad, pulse, and tissue Doppler to study the relationship between the atrial and ventricular contractions, and also simultaneous SVC and ascending aorta Doppler allows for defining the rhythm. A heart rate more than 180, a heart rate less than 110 are abnormal. Defining the AV relationship will allow specific treatment. If it was a short VA interval, it means there is an accessory pathway with a heart rate is about 230 to 280. If we have a long VA interval, could be a sinus tachycardia, FAT, or PJRT. VA and A superimposed, jet may be present. In atrial flutter, the heart rate will be 300 to 500. Treatment is reserved for fetuses at risk of heart failure. Transplacental digoxin, flecainide, and sotalol are the most commonly used first-line drugs. Complications of prematurity are more harmful than the risk of treating the fetus in uterus. Radiofrequency ablations of preterm hydropic newborns had been successfully attempted. Bradycardia is mostly benign, but it may indicate a long QT syndrome in the fetus. Complete heart block is associated with maternal immune disease and is usually irreversible. However, dexamethasones may reduce the risk of progression. So, cardiac ablation. Radiofrequency ablation progressively used as a curative therapy for tachyarrhythmias in children with congenital heart disease. 3D mapping and non-fluoroscopic navigation techniques and enhanced catheter technology have further improved safety and efficacy in congenital heart disease with complex tachyarrhythmias. Cryoablation is emerging as an alternative technique. Radiofrequency ablation involves Parkinson-White syndrome's most frequent form of symptomatic tachycardia. More than 15 kg in well-established radiofrequency ablations. Success rate is 90%. It's higher for left-sided pathways. Fluoroscopy time here is less than 40 minutes. Overall procedure time less than 240 minutes. And the risk for late SVT recurrence will be 5 to 10. What's the complication of radiofrequency ablations in children? Death. The overall estimated is 3 to 4%. The first one is death. It's related to respiratory arrest, intractable heart failure, thromboembolism, and coronary artery injury. IV block, it is the most common complication, 2%. It requiring a lifelong pacing. Operator experience has a major impact. Thromboembolic, 0.6%. Heparin does not protect against these events. Coronary artery damage and radiation exposure. Patients less than 15 kg has been reported to be associated with a high rate of complication after radiofrequency ablation therapy when compared to other children. Radiofrequency ablation in congenital heart disease, preparation for catheter ablation. Prior to invasive study, we have to have everything is ready. We have to have relevant clinical data, ECGs, echoes, cardiac CTs, or Amar if it is available, hemodynamics, and relevant surgical and catheter interventions. We have to have a screen for the peripheral and central veins and arteries for potential occlusions. Patients with congenital heart disease have often a high QRS complex during normal sinus rhythm, either due to congenital myocardial conduction defect as an Epstein or post-surgical myocardial scarring as in TOF. And an Epstein anomaly, pre-excitation, and AVRT occur in 20 to 30% of patients. It's technically challenging due to the large size of the right atrium and presence of multiple pathways in 50% of patients. Risk of coronary injury because of the thin arterialized portion of the RV. In the CCTGA and accessory pathways are present in 2 to 5% of patients, typically located at the left side of the valve. The coronary sinus serves as a landmark for orientation. A special form of AVRT can occur in patients with the corrected TGA, complete AV canal, and heterotaxia syndrome, and this is mediated by a twin to AV nodes. Diagnosis can be suspected if spontaneous alteration of the superior and inferior QRS axes are notified during a basal rhythm. Recurrence after radiofrequency ablations is up to 25%, and it is more in the small children. Multiple accessory connections are more complex anatomy. Radiofrequency ablations for accessory pathways can become very difficult and less successful after surgical interventions, such as infantile operation or AV valve replacements. Therefore, ablation of an accessory pathway should be considered prior to surgical intervention, even in asymptomatic patients. In the classical Fontan patients, ablation success is frequently hindered by multiplicity of mechanisms and substrate sites, as well as by the limited lesion formation due to thickened right atrial myocardium. Recurrence is about 20 to 30% after the first 3 years after ablation. And in the modern tunnel type, etc. cardiac Fontan operation, there is a less complex arrhythmia, but a more difficult venous success due to less extended atrial surgery. What is the potential complication of ablations in Fontan patients? SA or AV node damage, thromboembolism, myocardial perforation related to transeptal or transbuffal punctures, and damage or occlusion to peripheral veins or arteries. Systemic anticoagulation is advised for 3 to 6 months for any left-sided pulmonary venous lesion after radiofrequency ablations. Radiofrequency ablation in VT in congenital heart disease, this typically occur after cardiac surgery with ventriculotomies or ventricular muscular resections. It's mostly after repair of TOF, VSD, and Rastelli procedures. It's a predominantly macro reentrant circuit rather than focal automaticity. Success rate is 50 to 100%, recurrence 9 to 40 after 2.5 to 4 years follow-up. Non-fluoroscopic navigation system. This is our one aspect of the concern in ablation is the considerable radiation exposure to our small babies, as well as the physicians and the staff working. Non-fluoroscopic 3D navigation systems have been developed. We have the Localiza system from Medtronic, and we have the Nexus system from the Sanjur. Both systems have been reported to increase the efficacy and decrease fluoroscopic exposure and total procedure time. 3D mapping. The electroanatomical mapping system. We have the CARTO and the non-contact mapping system. The Nafees Insight 3000 Sanjur Medical permits a construction of a virtual 3D map of the selected chamber. And the tip of the mapping and ablation catheter is displayed on computer screen, allowing catheter manipulation without fluoroscopy and therefore significant reduction of radiation. Cryomapping. It was first described in 1977. We have here the cryo energy. The benefit of this system of radio frequency ablation is its ability to find the most suitable site for ablation through transitory electrical paralysis of the heart tissue in contact with the catheter tip. It's frozen to -30. This is a cryomapping. And if the site is suitable, then the tissue causing the arrhythmia loses its excitability. A permanent lesion is created then, and with a further freezing to even lower temperature, which is the cryoablation. Indication of catheter ablation in pediatric population. Catheter ablation is increasingly used in children as an alternative to antiarrhythmic drug treatment. In experience centers, it can be performed safely and effectively, even in very small patients. However, a major complication, especially the AV block, requiring lifelong pacemaker, should carefully weigh against the natural history of arrhythmia and the risk of the side effects of the medication. It is therefore recommended to consider radiofrequency ablation in infants and children only when antiarrhythmic therapies have been failed, including class 1 and 3 antiarrhythmic drugs. This is a table showing the indication for catheter ablation in children with or without congenital heart disease. Mostly, we are talking about the Walsh-Parkinson-White syndrome and the recurrent SVTs more than 5 years of age. Ablation procedure in children should be done in specialized centers by a pediatric electrophysiologist or an adult electrophysiologist experienced in pediatric ablations in collaboration with pediatric cardiologists. The center should have an ability to treat children, including cardiac surgery and anesthesia. There should be a cath lab for pediatric catheterization, as well as EPs regarding materials, equipment, and nursing staff. 3D mapping, non-fluoroscopic navigation system to reduce the radiation exposure. And older children can be done under conscious or deep sedation, and those less than 10 may need GA. Catheter ablation in small children needs specific modifications to lower the risk of vascular or cardiac injury. These include the use of 5 French catheters, the use of single EP catheter for both the atrial and ventricular pacing, reduced power and temperature settings, and the use of short-taste lesions. Few notes about the pacemakers in children. Yeah. During the last decades, pacemaker technology has developed rapidly. Pacing size generator has diminished and pacing leads have become progressively thinner. This makes the cardiac pacing in children much easier. The rate of lead-related problems in pediatric patients is high, about 15%. Predictors of lead failure included younger age at implant, congenital heart disease, and epicardial lead replacement. The survival of modern steroid-eluting epicardial leads is good and can be considered equivalent to that of endocardial leads, with a survival of about 95% in 5 years. Early complications of the endocardial leads, including the lead dislodgement, pocket hematoma, pneumothorax, heart perforation, cardiac tamponade, and device-related infections. Epicardial pacing complications related to thoracic surgery, including the bleeding, post-pericardiectomy syndrome, and cardiac strangulation. The most difficult complication of cardiac pacing in children in all age groups is pacing system infection, which is more in Down syndrome. Paradoxical thromboembolic events in patients with intracardiac shunts may occur at any time of device implantation. Long-term pacing studies have revealed that pacing the apical RV can cause LV dysfunction. That's why in the last years there is different sites for pacing, including the RVOT, the septal pacing, and sometimes LV pacing in pediatrics. This is the consensus panel recommendation of preferred pacemaker implantation access and modes. If the patient is less than 10 kg, then it's an epicardial device. If it is 10 to 20, still it is an epicardial preferred, and more than 20 kg, it's an endocardial device. Indication for cardiac pacing, class 1 indication, complete congenital AV block in newborn or an infant with a heart rate less than 55 or with congenital heart disease less than 70. Complete congenital heart block with wide complex escape rhythm, complete congenital AV block beyond the first year of life with an average heart rate less than 50, advanced second or third degree AV block associated with symptomatic bradycardia ventricular dysfunction, and postoperative advanced second or third degree AV block, not expected to resolve or persisting after at least 7 days after cardiac surgery, and finally the sinus node dysfunction with correlation symptoms due to an age inappropriate. Just a few words about the ICDs. The lower incidence of sudden cardiac death in pediatric population estimated to about 1.3 to 8.5 per 100,000 patients has limited the number of device implants in the pediatrics. Implantation of an ICD after cardiac arrest produce a survival benefit in adult survivors. Small pediatric observational studies also shown some benefits. Class 1 indication of ICD in pediatrics, including secondary prophylaxis after cardiac arrest, where no reversible cause have been found. Symptomatic sustained VT in patients with congenital heart disease, symptomatic sustained VT in patients with cardiomyopathies, and significant LV dysfunction. And this is the second class 2 indications, congenital heart disease with recurrent syncope with long QT intervals, long QT with medication non-compliance, HOCM patients, AV, arrhythmogenic RVs. Complication of ICD, lead complications, inappropriate therapy, and arrhythmia storm. Technical implantation issues, the children above 20 to 25 kg, the ICDs may be implanted in the chest wall, those between the 10 to 20, it's an abdominal side, and those less than 10 kg placement of generator is possible in the abdomen, although epicardial placement of the leads is required. And a patient with congenital heart disease with no access to cardiac chamber, still the epicardial system is required. In the last few years, we have a leadless ICD, and it's available for adults and for patients more than 40 kg. Counseling is very important in pediatrics. The occurrence of electrical storm is often followed by extreme psychological stress and fear of further shocks. Patients with ICDs are commonly allowed to partake in non-competitive, non-contact sports. Thank you very much.
Thank you very much, dear Dr. Alkubaisi, for your educational lecture. It was really, really useful. Thanks for joining us.
You're welcome. I know it's a long story.
Yeah, it was really complete on this field. Thank you. And for again, I'm going to give the warmest welcomes to all dear colleagues and friends joining us from all around the world on behalf of the executive team of the Congress. Thank you for joining us. I'm going to note again that please make sure your microphone is muted and your videos are off. Do not forget to log in with your full name in English, and do not forget to register on our application site in order to receive your certificate of attendance. Our dear Iranian participants can receive CME credit from irmce.ir. So please do not forget to join to attend the exam at the end of the session. And now I'm going to ask dear Dr. Hamdi to give the next lecture on long QT syndrome.
Well, thank you. I don't know whether you hear me or not.
Yeah, I can hear you completely. Yeah.
Okay. So can I go to share screen to have my presentation?
Now you are co-host here, Dr. Hamdi. You can choose share screen.
Okay.
And choose your screen which you want to be.
And then I should say share.
Yeah.
Okay. Let me see, where is my desktop?
Yeah, I can see it.
It's supposed to be somewhere here. I'm not sure whether I can get it or not. Oh, because my screen is not very clear now. I don't know. Can you help me how to find my desktop? Because
I don't know.
I don't know how to do this.
Dear professor, can you see your screen right now?
Yes, I can.
Okay, so can you open your PowerPoint?
Which is on my desktop supposed to be.
I can see it actually. It's on the right corner of the screen, long QT syndrome. I think you should move the Zoom screen.
On the right side of my screen,
yeah,
all the things are scattered. So
I think you should move. I think you should move the Zoom screen to the other side of your desktop so that you can find your PowerPoint, because I can see it, long QT syndrome.
Yeah, I got it now, yes.
I can't find it, Mariam.
That's a
yeah,
sort
you
of
should
a
have
magic.
good eyes.
Yeah, of course.
Okay.
Maybe I don't have.
So shall I open it now? All right, it's going on. Yeah.
Perfect.
Okay, can you see my first slide then?
It hasn't opened yet, but it's opening.
Okay. Well, thank you, Dr. Aso, for asking me to give this talk. Shall I enlarge this in a full screen now?
Yeah.
All right.
Please.
Okay. Right. Long QT syndrome, yeah, as all you know, especially in adult and in pediatric, that this is a sort of surface ECG finding, actually. That's the main thing, which is associated with high risk of dangerous arrhythmias, torsade points, VF, and sudden cardiac death. The normal QT, 360 to 420. Long QT syndrome has been identified as a genetic disorder and an incidence of 1 in 3,000 of the population, but this varies with ethnic people, with different parts of the world. In Iraq, we are seeing cases, surprisingly, not limited to pediatric. We are seeing a lot of adult cases of long QT, which we cannot say purely congenital, but we don't know why. They are not ischemic, as you will see in a minute. In males, the corrected QT maximum is 450. In females, 460. The hallmark arrhythmia is VT and VF, and the primary symptom is syncope. Risk of sudden cardiac death in children and young adults, and even in older age group, what we are seeing. This is just a historical review. In 1957, first QT syndrome family being reported, and then in 1971, a therapeutic approach by Moss and McDonald, which is gangliosympathectomy, has been introduced. And then over the years, many long QT syndrome loci and hundreds of mutations has been identified. The arrhythmias we see are VT. Sometimes we see atrial fibrillation, atrial flutter, AV block, and sinus arrest. We may see in long QT syndrome. How we identify the ECG changes? A QT syndrome, a QT corrected more than 460 by itself is enough to diagnose long QT. But sometimes we see a borderline QT in the range of 440, but with bradycardia or abnormal T-wave morphology makes the diagnosis more clear. And sometimes we diagnose long QT on basis of syncope or torsade VT in a family of long QT. It is either congenital and autosomal dominant, rarely recessive especially when other congenital abnormalities are associated. Acquired long QT can be caused by drugs mainly, electrolytes, and other non-specific factors. The three common types of QT we see in clinical practice are three types. Long QT syndrome 1, which composes about 54% of the cases. It has a high arrhythmic risk, and it has a specific type of T. And you can see this in this example, that there is a characteristic T wave, which is broad-based, high amplitude. While, in long QT2, which is also a high arrhythmic risk with adrenergic stimulation, induction of VT or VF, the T wave is biphasic, as you can see in this example, and it has an STT, low amplitude in the limb leads. While in the rarer type of long QT3, which are about 6 to 10%, it has fewer events, more lethal, happens during sleep. And the T wave is high-pitched, but a narrow base. This is the long QT. The other types are not really clinically identified well, and there are others than these shown in this slide. That is how we measure the QT clinically. You always should measure the QT manually. Never rely on what we call technical analysis or whatever the report of the ECG is coming through. You should measure the QT manually. There is no actual treatment, but beta blockers is a major treatment, and then the ICD. Gangliosympathectomy is very important, highly effective. This is the first family we met over the years. Sajjad, Saif, and Hussein. Two brothers died at the age of 9 years. One sister died at the age of 1 day. This is suspicious. 20 years old, this is the one, the first member of the family, recurrent dizzy spells, 2 near fainting, and recurrent palpitation. And you can see this is at QTC 512 with a broad-based T wave with a bradycardia. And you can see the arterial pacing here through his ICD. And this is one of his VF after implanting the ICD, where you can see the two channels, atrium on the top, ventricular, this is a VF actually, and defibrillated successfully here, and he recovered. He is still alive, enjoying a good life. He had his ICD changed 3 times, but unfortunately, sympathectomy has not been available to him up till now. And this is his brother with a QT type 2. We can see that how long, very long QT with characteristic T wave, biphasic. So we can see in the same family different types of long QTs, 1, 2, 3, or even the other types in the same family, surprisingly. And this is one of his VT during his ICD, where we can see how fast is the VT, and then cardioverted here and returned into sinus rhythm. This is the third brother. He has no documented VT, but his QT is on the borderline. It's about 480 or something like that. But unfortunately, we lost the follow-up of this family, and we don't know what happened to this third member. This is another patient, 4 years old boy, recurrent syncope, diagnosed as epilepsy, and put on anticonvulsant with no improvement. Mother one day noticed very rapid pulse at his neck and chest wall during syncope. And then he was referred by the pediatrician as long QT syndrome. This is actually a type 2, QTC 629. This is an adult, 50-year-old man, recurrent palpitation with dizziness, and his QT in the range of, sorry about this, I can see it well here, okay? It is almost about 500. And this is one of his recorded clinical VT, which is very, very fast. Coronary artery disease excluded, electrolyte normal, no drugs responsible for his QT. So he's 50 years old. And this is his ECG during EP study, where we could, by ventricular stimulation, induced almost the same clinical VT, which is terminated by anti-tachycardia pacing, fast pacing, and then he is in sinus rhythm. And this is one of his VT from his ICD, where the VT started here and continued here, and then an ATP without a shock. This is one of the nice function of the ICD, where you can terminate the VT without shock by fast anti-tachycardia pacing, and then he's in sinus rhythm. This is 10 years old, recurrent fainting. Two brothers died suddenly at the age of 12 and 8 years. The QT in the range of 480 or something like that. And this is his ICD recording after implanting the ICD. You can see this is the arterial channel, and this is the ventricular channel in dual chamber. And this is the VF where it started here. And then the first shock didn't revert it. The second shock didn't revert it, but the third shock, fortunately, reverted into sinus rhythm. Unfortunately, in this patient and the others, sympathectomy is not widely available here in our practice. That's very unfortunate. This is 9 years old boy, recurrent fainting, brother sudden cardiac death at the age of 12. His QTC 510. This is a QTC1. And look to the T wave. This is very important. Not only the QT is long, but the T wave is alternating, as we will see in the coming example, how the T wave changes over the 24 hours of the day. That's a very important risk in patients with long QT, changing T wave. And this is again from his ICD, where we can see the VF starts here, and this is the atrium, and the VT and the VF is very fast, and the first shock didn't revert him into sinus rhythm, while the second shock fortunately reverted him into sinus rhythm. This is his brother with a QTC 494. He refused, the family actually refused the ICD. This is an adult with recurrent dizzy spells with palpitation. What you can see, there's a 2-to-1 AV block with a long QT of about 600. Look to the QRS here and look to the QRS here. He is developing a fascicular block. In addition to the AV block, he has a fascicular block. And then you can see how long the QT is. This is one of the presentation of AV block in long QT syndrome. Coronary artery disease excluded, electrolyte normal, no drugs responsible for his QT. And this is his polymorphic VT, or what we can call VF almost. And she received an ICD. This is 18-year-old boy presented with fake chest pain. Somebody asked for exercise test. Look to the ECG, very long QT, no family history of sudden death, all causes of acquired long QT excluded. So this is most probably a congenital one, and a QT of 595, and the T wave is inverted. And during exercise, he fainted, but unfortunately, they couldn't actually record the rhythm during fainting, and somebody reported there is a non-sustained VT. He received an ICD, but we lost his follow-up. This is a 21-year-old female with recurrent palpitation, where you can see the her QTC is 489. This is a type 1. And this is a clinical white complex tachycardia where you can see a fusion beat in the middle, characteristic of ventricular tachycardia. And this is taken from his ICD, where you can see the fast VT, and then a shock came here and reverted into sinus rhythm. 2-year-old boy from Sulaimani with recurrent vague dizzy spells. 2 sisters, sudden cardiac death at the age of 2 and 3. The QT here is not very long, in the borderline, 440. You can see the sinus arrhythmia, which is common in children, but still the QT over the days of Holter monitoring is variable. The longest recorded 484. With this family history, with this variable QT, we put an ICD. She is still alive. She's about 17-year-old now. Her ICD replaced once, and she has a sympathectomy done abroad. She's doing very well, but her ICD should remain in. Okay, this is an adult, 31-year-old from Kirkuk, referred to me with recurrent, very fast ventricular tachycardia, almost ventricular fibrillation, defibrillated successfully several times. What is behind it? Very recurrent in the CCU, and this is her sinus rhythm ICG after stabilization on beta blocker therapy. What we can see, a QTC borderline, not very long. Look to the T wave, normal. Look to this T wave here. There is a T wave changes, and the QTC now is 475. And this is a QTC borderline and even normal, but the T wave is alternating. And this is here another T wave and another T wave and a long QT. So QT normal with a T wave changes with recurrent polymorphic VT should diagnose long QT syndrome. And this is her atrial fibrillation through her ICD, where you can see the atrial channel is very fast. The device defibrillated this into sinus rhythm years after, about 10 years after presentation. She was very well, doing fine. She had 2 pregnancies and deliveries normal, and she has a VF and defibrillated successfully, right? Stabilization on beta blockers in long QT never immune the patient against ventricular fibrillation. This can happen anytime in the future. This is an adult, 42-year healthy housewife, presented with atrial fibrillation, which is very common arrhythmia. But when we look to the QT, it is 495. And this is another long QT in the borderline. And this is her ventricular tachycardia. It is monomorphic. This is unusual in long QT. Usually the VT is polymorphic in long QT, but this is monomorphic. Differential diagnosis here is long QT, one of them, but ARVD, idiopathic RVOT should be considered and should be carefully differentiated. Adult, 54, recurrent palpitation, very wide, complex tachycardia, highly suggestive of ventricular tachycardia. All underlying pathologies excluded, mainly ischemic dilated cardiomyopathy. Drugs are not responsible. He is 54. And this is his QT 524, very long. With bradycardia, this is another issue in long QT. When you see bradycardia and you correct the QT, and it is long, this is highly significant. This is a 9-year-old boy presented with recurrent syncope for 1 year. No fits, otherwise active, healthy, negative family history. And his QT 529. And T wave changes. And another one, 571. These are 2 sisters, 1 brother, 1 sister, adult, 1 30 years, and the other patients 35, 1 male and 1 female. This is the first one. a 485 QTC with these symptomatologies of recurrent dizzy spell has been diagnosed as a Brugada syndrome, but we couldn't see a clear-cut ECG changes of Brugada, but a long QT. And after ICD implantation with this malignant family history, she developed VF after 1 year and defibrillated successfully. And this is her brother with a borderline QT, but no significant arrhythmia diagnosed, and he refused the ICD. This is the youngest I have seen, 6.5-month-old male, admitted to hospital when he was 2.5 months old as a case of near drowning. This is very typical at this age group because of loss of consciousness during bathing. Also, he had the same attack when he was 45 days, but the family didn't consult a doctor. ECG being ordered, and this is his QT 520, and this is his one of the many VF attacks developed. What we can do at this age group is only 6.5 months, right? Shall we implant an ICD at this age group? And what type of an ICD? Epicardial ICD are not available here. So we are being enforced, this is the child, we are being enforced to put an intravenous ICD. And this type of lead is only single coil, not dual coil as in adults, right? And we keep a loop. You can see this loop in childhood, and even in pacemaker, we keep a loop in the RA so that when the child grows up, this will not retract or displace the lead. He had several attacks of VTVF, but sympathectomy supposed to be done abroad, but unfortunately he had a storm of VT and VF, and he died before the sympathectomy has been done. And this is one of his VF recorded, and DC cardioverting him into sinus rhythm. The other two, this one also is a very typical 6'5", 2 years old, also diagnosed as epilepsy, and then the mother noticed that she has tachycardia, and look to the T-wave shape. T-wave inversion, and this tall, narrow base T, this might be a long QT3. And that's all what I have in this very short survey or review of clinical cases I have seen over the last almost 15 years. But how much cases we are missing in pediatric and even in adult? I am sure there are a lot. They are overdiagnosed as other cardiac pathologies, but calculation of the QT, listening to the history, considering the sudden cardiac death history in the family, make us more oriented to not misdiagnose this fatal condition. Thank you very much. Okay.
Thank you very much, Dr. Al-Hamdi. It was a very nice presentation, but by you, I do really learn from you, sir. And it was very exciting for me that you have so many cases referred to you from other parts of Iraq. Can I ask, do you have a cath lab for this purpose in Sulaimani?
Yes, we have one private, actually. We're doing limited EP.
Mm-hmm. And
especially AVNRTs, AVRTs, some accessory pathways, not doing VT, not doing atrial fibrillation, but we implant all kinds of devices, not a subcutaneous ICD anyway.
And you're working on pediatric group, yes?
No, I'm not a pediatrician. I'm an adult electrophysiologist, but there is nobody doing pediatric cases. So I hope one day one of the pediatric cardiologists will be encouraged to go through pediatric electrophysiology. That's what we actually need.
Sir, it was a great honor for me to know you, and I do appreciate what you are doing in Sulaimani. And thank you very much. And your cases was very interesting for me, and I'm sure very soon we will have very good news from Sulaimani about the pediatric patients. I'm sure that with such a scientist as you, and also with the help of Dr. Asu, you will have a very good experience with pediatric group very soon. And can I ask you a question that is in my mind? How can you consult your patients with suspected long QT syndrome about their activity? There are some cases that have events and they are going for ICD implantation, but some of them are living with their long QT, and how can you consult them about how can they go on with their lives?
Well, in the adult age group, we usually limit their activities. Very rarely they ask for sports, for example. We don't allow them to, in general. That's our rule. Second, beta blockers should be given in the highest tolerable and should be taken all the life regularly. And that's very important. Also, that's applied to pediatric. We educate the family. We give the beta blockers in the right exact dose according to the body weight. We go from 3 milligram per kg, then we go to 5 milligram per kg, right? Even higher than that, 6 milligrams per kg, provided there is no hypoglycemia. And I noticed that the majority of the pediatric, they tolerate this high dose very well. I don't believe in long-acting beta blockers. I usually give it exactly 8 hourly. And this should be taken all over the life. Unfortunately, as I said, sympathectomy, cardiac sympathectomy, is not available to us up till now. And we send them sometimes to Tehran, sometimes somewhere else. And even in Tehran, we face difficulties in finding a thoracic surgeon to do this sympathectomy for us. Okay, Dr. Hassan?
And sir, which beta blockers are, in your opinion, are the best to give to such patients?
Propranolol still is the best, but sometimes we go to nabivolol. But still, propranolol, the oldest beta blocker, is the most effective.
Mm-hmm. And sir, can I ask you about the exact criteria? Because I know you are so experienced, and I can see that when you talk about the arrhythmias, it's so familiar for me that you are working day by day with these patients. So can I ask you for your personal approach to a patient with long QT syndrome? You know, there are some criteria that we are using by books. So you, as a person that is in charge for so many patients, you know, how can you approach? And you have, as you can see, we are so many residents here with us, and they are listening. So what you can say them and learn them as a take-home message?
Yeah. First of all, Dr. Hassan, first point is considering the symptomatology, documenting the arrhythmia. Second, the family history. If there is a positive family history of sudden cardiac death, whatever the QT is, even if it is not very long, we implant an ICD till sympathectomy will be available and beta blocker therapy. That is the main thing. If there is a negative family history and the QT is more than 500 with documented arrhythmia, we go into an ICD. That is applied to long QT 2, 3. But in 1, a lot of people nowadays try to avoid ICD. But that is not a solid rule. If you have a sudden family history of sudden cardiac death, you cannot avoid ICD. The ICD in pediatric is a real problem regarding the psychology of the child, the family understanding, when the patient receives shocks, how you educate them. So it needs a lot of work before you decide to put an ICD. I think if sympathectomy will be available, we may be able to avoid ICD implantation in long QT1 and long QT2, but not in 3. Finding other congenital abnormalities in pediatric, like these syndromes, deafness, for example, we don't see deafness here. I don't know why. We haven't seen deafness with long QT in pediatric age group in Iraq. Possibly Dr. Aso may help.
Sir, there is same experience. I have same experience as you in Iran. I haven't seen any cases of deafness with long QT syndrome in so many cases that are referred for us, because
absolutely. I'm glad, Dr. Hassan, I'm very glad to hear that.
Oh yeah,
I'm very glad to hear that.
Definitely agree. Definitely agree, Doctor. I definitely agree with you, because I saw 3 patients also. Now one patient present before in a neonatal age at 6 days of age, with history of 2 deaths in the family, and that's 1 week before. But the family, they were concerned about the baby, that they lost 2 patients, 2 kids before. Now there's the newborn baby, 6 days. I just accidentally found the long QT syndrome without any deafness and other. So yeah, I agree with you, doctor. Yeah.
Okay. Unfortunately, genetic studies are not available to us up till now, Dr. Hassan. What about in Iran? Is genetic studies available widely?
Not widely, but there are centers that can help us with that. For example, sir, I have a case that was very educational for myself. It was a child with neurodevelopmental delay. On echocardiography, there was hypertrophic cardiomyopathy, and the parents were closely related. They were cousins. And there was long QT syndrome. I think it was biphasic T's, and the QT was about 530, and I referred it for genetic testing, and it was a case of, I cannot remember the exact gene, but we found the gene that was responsible for all the situation together.
Yeah. Well, we hope we can have that one day. I don't know.
Sir,
nobody is interested.
So many cases. I know.
Yeah.
So you have so many cases, and you have so many talented physicians back there. I'm sure there will be, with what I can see with you and your colleagues, I'm sure there are so potentials back there in Iraqi Kurdistan for such equipments. You know, there's nothing for you because you have the science. The equipment will be soon in your hands.
Well, we hope one day we will have a national registry of
sir,
these cases. I talked to many pediatricians, and we didn't actually have, I don't know why, we didn't see all these cases. We need to have a registry, a national registry in all Iraq, to follow up the families and to have a genetic testing and to discover them so early in life. I hope that can happen one day.
Sir, I want to ask you if it is possible for you and Dr. Asu, we can arrange another meeting after the Congress on the exact solely on the topic of long QT syndrome, and I can arrange to have some of the most well-known pediatric and adult EP men here with us, and we can talk about it much more concisely, and if you agree with me.
Yeah. I will be very glad. I will be very glad to do that.
I'm so happy to hear that. So
very good idea.
So also
we can arrange that.
Also, it is in your hands to bring Dr. Al-Hamdi with you, and let's arrange it for the future.
Yeah, sure.
For just for the last question from Dr. Hamdi, if I may, I want to ask him, sir, for a patient that I know you do not work with pediatric group, but it is I wonder if you go for you know, there are so many pediatric cases that present with SVTs during neonatal period. Okay, there was a tendency towards non-go for medical therapy during the first attack of the SVT. Is it any changes in your tendency toward non-going for the medical therapy in the first attack of the SVT in pediatric group in childhood? Do you agree with that, or you go for the therapy? You give them, for example, beta blockers?
Right. Okay. With the limited pediatric cases I have seen over the years, the majority of the first, second, third year SVTs are AVRTs, accessory pathways. They usually respond very well to antiarrhythmic drugs in that age group. But in later age group, if it continues, then we go to ablation therapy after the age of 5 or 6 years. But if it is the only single attack, we don't give anything. We just watch. Especially the attack is well tolerated, which is usually so. It is almost very fast, whether it is AVNRT or AVRT in pediatric age group, much faster than the adult. So it is the rate which controls the symptoms. If the symptoms are well tolerated, first attack, do nothing, just watch. Or you may apply the rule of pills in the pocket, which we apply to adults, that we educate the family how to terminate the attack by Valsalva maneuver, or to give a drug on need. That's what we call pills in the pocket. But if the SVT recurred and became more resistant, then we have to go to oral antiarrhythmic if failed to ablation therapy.
And for the last question, I believe I have so many questions here to be asked also. And
you're welcome, Dr. Hassan.
And we found, thank you very much. And we find Dr. Al-Hamdi, and we are out of time, I know. So for the last questions,
we're glad to meet you, Dr. Hassan. We may meet in Tehran one day. I usually come to see my dear friends, Dr. Saeed Orai, Dr. Mahmoud Iftimir Ma'soumi, they are very close friends to me. They usually come to Sulaimani and visit us every now and then. Yeah, you know, we have good relations.
Dr.
For the last
is also
15
a very
years or
good
something.
teacher and friend of mine. Dr. Al-Hamdi, the last question is that...
you're welcome, Dr. Hassan. Nice to meet you.
Thank you very much, sir. Thank you very much. The honor is ours.
And thank you, Dr. Hasso, for inviting me. I'm sorry I am a bit late because I have to do a pacemaker urgently.
Dr. Al-Hamdi, the last question is that what is your experience with treatment of the post-surgical jet? Do you have any cases back there in Sulaimani?
Well, I am not seeing much of those because I'm not involved in the pediatric surgical department much. Possibly Dr. Aso see them more than I do. But the few cases I have seen according to the body weight, loading dose, and then oral if it recurred. But amiodarone IV, loading dose is very effective.
And sir, do you agree that we can use amiodarone instead of a loading dose? We have a very bad experience with the patients that we have a loading dose of amiodarone administered in a short time, they go for complete heart block after the surgery. And even we had some cases that were expired because of the loading dose of amiodarone. So there is a tendency in our ward towards the administration of amiodarone as a stepwise drug. You know, for example, we give a very low doses of amiodarone, and then about half an hour.
That depends on the type of surgery, Dr. Hassan. If your surgeon actually has sutured near the AV conduction or the his bundle, and you have a long PR interval post-surgery, that's more possibility amiodarone may induce high-grade AV block. But if the PR interval is normal, the QRS is narrow, so this is usually very rare.
And also, do you agree with me that amiodarone can cause complete heart block if it is administered fast in pediatric group?
Yeah, you mean in cases of JET post surgery?
Yes. Yes.
Yeah. Really,
have you any cases?
Yeah. We had at least we came across. Really, I came across 6 patients. 2 were with the foreign teams, they were working here, and 4 with our team here. So fortunately, all of them alive, but we use with the foreign teams, really, there's 2 protocols they were using. One is, it was the giving 10 milligram per kg loading dose when the PR interval is normal, or the second one, it was the in 20 minutes, they are giving 2 milligram per kg IV shoots, like giving a shoot of amiodarone for 5 occasions over 1.5 hours. So it's effective in some cases. That's Texas University way to do it. We learn from that school, but usually. But sometimes when one of my cases with one of the foreign teams, we were obliged to give other medicine with it, like and other anti-arrhythmic drugs. Even we opened the chest and put in ice around the heart. So that was one of the options done by one of the surgeons, foreign surgeons, and was successful.
Thank you very much. Thank you very much, especially to our lecturers, dear Dr. Asu, dear Dr. Hamdi, dear Dr. Ahmad Khalid, and dear Dr. Firas Alkubaisi, if I pronounce it correctly. It was a great honor to meet you all. And sorry, because we are late for the next session, I should go back to our facilitator and moderator. So Mahia, back to you.
Thank you.
Thank you very much.
Thank you, Dr. Hassan. Thank you, Dr. Aso. It was nice to meet you.
Thank you, Dr. Alam. Thank you, Dr. Alam.
You're welcome. You're welcome. Thank you. Bye-bye.
Bye-bye.
Bye. Thank you all of you for joining us with our Arrhythmia in Pediatrics session. The next session we are going to have is FTT updates, failure to trieve updates, and we will be back in around 5 minutes. Dear Iranian participants, please do not forget to attend the exam at the end of this session in order to receive your CME credit. See you soon.